And I don't know, they used to give us questions where they give you the hemoglobin, a change in hemoglobin, a change in cardiac output, a change in SAT, and they'd ask you to say which one benefits you most in terms of oxygen delivery. So, cardiac output is most important. Hemoglobin is next. So if you go from a hemoglobin of 8 to 10, you've increased your oxygen delivery by 20%. Percent SAT, not so much, because if you go from 93 to 95, not a big deal, right? And your PO2 is your dissolved oxygen. That's really not that important, although some people will tell you that's important in head injury, right? But in the general population, that's not really important. So when I get a blood gas, I'm really worried about the saturation. And I'm not really worried about the PO2. So the nurse or the therapist that's a newer therapist comes to me, but the PO2 is 70. And it's like, I don't care. I'll be nice in this audience. What's the SAT? The SAT's okay, I'm happy. Now the other thing though, you have to take the SAT in the context of the pH. If you got a pH of 7.6 with a SAT of 90, I'm not so happy. Because you got a leftward shift of your oxyhemoglobin dissociation curve, and you're not delivering oxygen to the tissues. You know, if you got a PO2 of 60 in an acidemic patient, you're probably getting pretty good oxygen delivery because you've changed your saturation curve to the right, your oxyhemoglobin dissociation curve. So it does, but in the context of the normal pH, or near normal pH, it's really all about your percent SAT is like, that's what you want to know. You want to know that you're maintaining a decent cardiac output and that your hemoglobin's okay. And that's what you need to know. And PO2s are sort of non-relevant. So as long as you keep your patient in a reasonable SAT, you don't worry about the PO2. As far as oxygen, most papers will tell you that as long as you can maintain an FiO2 less than 60%, you'll probably avoid oxygen toxicity. If you look at pulmonary function tests post-ventilators, people that are maintained at 60% or below will not have major changes in their diffusion capacities on PFTs. People that have a higher FiO2s will have changes in diffusion capacity. And that's the most sensitive indicator of some early interstitial process. So it's about cardiac output, hemoglobin, and saturation. Okay, so physiological effects of mechanical ventilation. What are the physiological effects of mechanical ventilation? I told you already. Should have asked you before I got to this slide. Close your eyes. No, so if you think about it, when we breathe spontaneously, we inhale, right? When we inhale, what do we do to our intrathoracic pressure? It's negative. When your intrathoracic pressure is negative, you get better venous return. When you're on a ventilator, you're never below atmospheric pressure. If you even hit that, if you're on PEEP, you'll never even get the atmospheric pressure. So you have less return of blood to the central circulation. You do squeeze blood out of the right ventricle, though. Okay, but you don't allow return of blood to the right atrium. So you do get left-sided preload augmentation by squeezing the blood out of the pulmonary circulation into the left side, and you also decrease afterload. Because your afterload is determined between the pressure around the pericardial chamber and the pressure in the chest. And since you become less negative, the pressure change is less between the two cavities, and you have afterload reduction as well. So you get preload reduction, afterload reduction. So mechanical ventilation is a great thing for people in CHF, because you're doing exactly what you want to do for the heart. You want to preload reduce it, you want to afterload reduce it. When you preload reduce it, you're protecting the heart from volume overload. When you afterload reduce it, you're allowing the heart to unload more easily. When I wean somebody off a ventilator that's been in heart failure, sometimes I'll put them to a truly spontaneous T-piece, because I want to see what happens under physiologic circumstances and whether or not they're going to go into heart failure. I mean, Mary can tell you that we once had a guy that looked great on pressure support of 10 and CPAP of 5. We extubated him. He went into fulminant pulmonary edema, and it took us about 5 hours to re-recruit this guy. And she was beside herself. I was like, don't worry, it'll be fine.
He's good.
And he did great, that guy.
We did T-tube the next day, remember?
Yeah.
So,
But the next time we extubated him, we did it off of the T-tube to see what would happen. So the other thing it does, it causes SIADH. Because what you're doing is you're decreasing your venous return, your right atrium senses that, and you excrete antidiuretic hormone. Physiological effects, we already said. Increased FRC, preload reduction. If you put on too much PEEP and you start to impede cardiac output, you'll screw up your oxygen delivery. And when PEEP was first introduced, we used to swan everybody. We used to check cardiac outputs every time we dialed up the PEEP. Then we got into checking lung compliances every time we dialed up the PEEP. It was crazy. And we talked about auto PEEP. So auto PEEP is that entity created when you give them too much tidal volume, too high of a rate, and you can simply get rid of it by taking the patient off the ventilator, sometimes gently pressing on their chest to get rid of the retained air, and then putting them back on a smaller tidal volume and lower rate. We talked a little bit about pressure control. We have a couple patients in here on what's called APRV, which is really BiPAP on a ventilator. We have an oscillating ventilators here. We used to have a jet ventilator here. We used to do that. That's a quite different mode. There's other things when you get into the ARDSnet, what's called permissive hypercapnia. So you can use smaller volumes, allow CO2s to be higher to protect the patient's lungs. And we'll talk a little bit about that real quick. So, yeah, so what is the philosophy? I mean, do you guys all know about ARDSnet? Okay. So ARDSnet is what's called a lung protective strategy. So back in the day, we used to put people on bigger tidal volumes. We used to give them size, remember that? To like recruit them. So like in between every breath, every once in a while they get like a liter sigh.
double their tidal volumes.
Yeah, double their tidal volumes. We used to do all that kind of stuff. So people began to think, well, what is this doing to the lung? Like how do you and I breathe when we breathe naturally? What kind of tidal volume do we have? Not that big, right? So people started to notice that people that were on ventilators for longer periods of time developed multi-system organ failure. So what was the etiology of this? And they weren't sure. So it was some type of, harmful effect to the lungs, creating a systemic effect in the rest of the body, because all the blood goes through the lungs, right? So if there's an inflammatory process going on and all the blood goes through the lungs, maybe it's creating havoc in the rest of the body. So what they did is they took people and they put them on 6 cc's tidal volume versus 12 cc's tidal volume. And they found that there was a great mortality benefit from people on 6 cc's. And in addition to that, they found that if they had trouble oxygenating those people, they would give them high levels of PEEP. Okay, they would allow their PCO2s to be somewhat higher and target a pH of 7.15 or above. And they really wouldn't worry about oxygenating them in terms of PO2. They keep their SATs at a reasonable amount at the lowest FiO2 possible. And that's the ARDSnet philosophy. And the thinking is that if you give too much of a tidal volume, you stretch out the lung, the endothelial surfaces rip, you create inflammatory processes. These inflammatory mediators go out to the rest of the body and multi-system organ failure is engendered. Additionally, when you put somebody on volume ventilation and you think about a balloon, like when you blow up a balloon initially, what's it like to blow up a balloon initially? It's really hard, right? And then eventually the balloon opens up and it's real easy to get the air in. And then eventually if you overdistend the balloon, it's real hard to blow into that balloon again. So the ARDSnet is high PEEP so that you don't come back down to closing, so that on each breath you don't have to snap open, like you have to snap open a balloon, which causes trauma. You want to stay in a linear relationship between pressure and volume where it's real easy to inflate the lung, and you don't want to over-distend it so that you don't get to that point again where you don't get much bang for your buck as you put in volume, and again you're over-distending the lung and creating endothelial damage. And that's the whole ball game. And that's a philosophy. And so that's where the 6 cc tidal volumes come from, the 8 cc tidal volumes. You don't want to exceed peak pressures of 35, plateau pressures of 30. And independent of that, you don't want the volumes to be too big. Because you could say, well, what if I give them a big volume, but they don't exceed a peak of 35 and a plateau of 30? There's still, there's still an independent benefit from keeping a lower tidal volume. So it's not just about the peak and plateau, it's also about the tidal volumes. So that's the philosophy behind that. So I guess that's about it. Because that's a lot to start out with. But it's sort of an introduction to, respiratory failure and philosophies behind ventilating patients. You guys have any questions?
I'm out of air. I'm out of oxygen.
You're out of
too.
oxygen?
Yeah.
Roy, you have any comments
So
or
are you.
anything?
No.
You have any comments, Mark? I've been doing this for a while. It's interesting to see how things have changed over the years. It really is. What it all comes down to is just taking good care of the patients. I mean, it really does. And paying attention to this, and this has been helpful, and it does make sense in terms of using smaller volumes. All right, I guess that's it. Thank you.